Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring the latest interventional techniques used in stroke treatment. We also discuss the role of GPs in the assessment and management of a stroke patient. This podcast is made possible by Macquarie University Hospital, part of MQ Health. Neurologist Candice Delcourt works at MQ Health Neurology, and Interventional Neuroradiologist Brendan Steinfort is with Macquarie University Hospital, and both join me now. Dr. Delcourt, what is the role of GPs in the initial assessment and management of a suspected stroke patient?
So I guess first, the most important role of GPs is in primary prevention of stroke. So by treating blood pressure, high cholesterol, make sure that patients quit smoking, we lower the risk of patients having a stroke very significantly. And so I think it's essential. It's an essential role from the GPs. But now, having said that, when a patient has a stroke, what's really important is recognition that the patient is having a stroke, and then rapid transfer to a stroke-capable hospital so the patient can receive acute stroke therapies if they are eligible for them.
What acute stroke therapies are currently available?
So current therapies for stroke includes antiplatelet agents, thrombolysis, and thrombectomy. So we'll give antiplatelet agents in patients who are outside of the time windows to receive thrombolysis or thrombectomy. Thrombolysis includes giving an intravenous drug, which in Australia is either RTPA or alteplase or tenecteplase, depending on the locations. And then thrombectomy, as discussed with my colleague Brendan, is mechanically removing the clot through an intraarterial catheter. And this allows to reopen large blood vessels because if a patient has a clot in a large blood vessel, thrombolysis, so just injecting the intravenous drug, is not very effective. So mechanical thrombectomy will be much more effective for these patients. Now, thrombolysis is quite widely available in Australia, including in rural and regional Australia, especially since the development of the telestroke networks. But thrombectomy, unfortunately, there are only 19 centers in Australia and 15 which are available 24/7. So that means that if a patient has a stroke in the country, in Australia, and requires thrombectomy, that patient might require to be transferred to one of the major tertiary centres.
We know that time is brain in stroke management. Can you elaborate on the critical time window for treatment?
Yeah, so time is brain. So for every minute lost after a stroke, we lose 1.9 million of neurons. So it's really, really important for things to be done really quickly to avoid loss of neurons and loss of brain. The way we look at that in our practice is we use advanced CT imaging, and more specifically CT perfusion, which will give us an idea of how much brain is already lost or how much brain is already dead, what we call the core, and how much brain is potentially salvageable if we manage to reopen the blood vessel, what we call the penumbra. So we use advanced stroke imaging in any stroke centers, and we definitely use advanced stroke imaging at Macquarie University Hospital also. So it's recommended, guidelines recommend to do thrombolysis within 4.5 hours of onset. So this window is actually quite short. And thrombectomy has a much larger time window that we consider around 24 hours, but it's very strongly based on what the CT perfusion shows. So interventionists and neurologists will together look at the brain CT scan and see if doing the intervention is likely to provide any benefit to the patient.
Please discuss the challenges and advancements that have been made in reducing treatment times.
Australia, unfortunately, has been lagging behind other developed countries in terms of timely delivering acute stroke care. But just last year, a group of Australian researchers and key stroke organizations developed some national stroke targets, which are actually called 30, 60, and 90 for times taken, or which should be taken to do some of these acute stroke procedures. And so there is a huge push in Australia to try to improve the time to treatment. And it's this in this 30, 60, 90, the 60 actually means that the time between the patient presenting to hospital and the patient receiving thrombolysis should be less than 60 minutes. And so how do we do that? How do we improve times? I mean, if we start at the very beginning when the patients or the family call and patients have stroke symptoms, so the key people involved at that time are ambulance paramedics. So training paramedics, make sure they recognize stroke is really essential. And then also for patients to be then transported to a hospital where they can receive acute treatment for stroke. And while the patient is transferred by the paramedics, there should be what we call an ambulance pre-notification to the receiving hospital. So they are ready. They know a patient is coming, and they can get the CT scan ready for when the patient arrives. So as soon as the patient arrives at the receiving hospital, they should be directly transferred to the CT scan. When as much information is taken from the patient, potentially the family and the paramedics, about history of the current event and medical history. So having the CT scan as quickly as possible to understand what's happening is really a very important step. And also, as soon as the CT scan has been done, a decision needs to be made about treatment. So thrombolysis plus or minus thrombectomy. Some patients can potentially receive both of these treatments. And ideally, thrombolysis should be given as soon as the scan is done and the doctors have made a decision. As I said, we use advanced CT imaging, so it takes a bit of time to put the pictures together. So this is also something we need to work on to make sure that not only the scan is done, but all of the pictures are actually accessible to all the specialists who will be involved in patient care. So this is a bit of a challenge. I mean, there are lots of steps. I think we're doing pretty well in most big centers, but we still can improve. And as we said earlier on, time is brain. So every minute we can spare is important.
How important is secondary stroke prevention, and what roles do GPs play in ensuring effective management and reducing the risk of recurrence?
So when someone has had a stroke, roughly the risk of recurrence is about 20% at 10 years. So this is here that we see the really key role of the GPs in working with us as neurologists at reducing cardiovascular risk factors and lifestyle issues such as smoking. So someone who has had an ischemic stroke will be given 3 types of medication: an antithrombotic agent, blood pressure lowering medication, and cholesterol lowering medications. And we definitely need the help from the GPs to ensure good patient understanding that these medications are essential to prevent further stroke, and also that patients are actually compliant with their medications. I think it's important to have a neurologist involved in regular follow-up of stroke patients. And we provide these kind of clinics here at Macquarie Health Neurology. In terms of general goals, it's important for patients to quit smoking. It's really essential for their blood pressure to be well controlled. And I would say even less than 130/80 in someone who has had a stroke, and have very strict control of cholesterol. So the total cholesterol should be less than 4 millimole per liter, and LDL cholesterol should be less than 1.8 millimole per liter. There is quite a lot of literature, especially in the cardiac field, to say that we should even be more aggressive with cholesterol. So we might in the next few years change these current recommendations.
Dr. Steinfort is going to talk to us more about the role of neuroradiology in stroke treatment. Can you walk us through the latest interventional neuroradiology techniques used in stroke treatment?
So my name's Brendan. I'm a neurointerventional specialist. My initial specialty was radiology and neuroradiology, then interventional neuroradiology. I did fellowships, the inaugural fellowship at Royal North Shore Hospital, and subsequent fellowships at Queen Square at the National Hospital of Neurology and Neurosurgery in London. Acute stroke treatment, or treatment of stroke within the first 24 hours, has had a little bit of a slow uptake in my career. Early on, acute stroke treatment was given with intravenous thrombolytic agents or clot-busting drugs, and subsequently there were some intra-arterial clot-busting drugs when we were using urokinase, and there were some mechanical devices like the Mercy device for which we could pull clots out of the arteries to the brain. But in the time that I've been working in this field, which is about 20 years, there's been the advent of stent retrievers, where we deploy a stent on the end of a wire within the blood clot and then pull the blood clot out, which has a much greater efficacy than intra-arterial TPA or the early mechanical thrombectomy devices. And that's now used in conjunction with aspiration, and sometimes aspiration alone, where large bore catheters are placed up against the clot and engulf the clot to help try to remove it. The latest advancements really are more about the patient selection rather than the technology. Our equipment's getting better and easier to use, but even when we look at the Extend IA trial, which was the pivotal Australian trial that was published in early 2015, we opened pretty much all the blood vessels. But what we're doing now is maybe opening them a little bit more quickly and getting full opening on the first attempt, which is very important for good outcomes. But there's been a whole bunch of randomized controlled trials that show not only our super selected population that we were treating these acute strokes for, very early, very good clinical grade, very high deficit, and very small cause, not only do they do incredibly well, and that increases the rate of patients that go home from 20% up to 70%. So it's like a miracle cure. It's better than cardioversion. It's better than antibiotics and sepsis. It's one of the most effective clinically and cost-effective treatments in medicine. So not only does that group benefit, but there's this whole other group of patients who present a little bit later, certainly out to 24 hours for the right patients, and who also present with larger, more established strokes, do well. Now, we don't get them getting to 70% get-home rates, but instead of having a 5% get-home rate, it goes up to about 30%. And the amount of patients that are left in the MRS5 category, the Modifin-Rankin score 5 category, the ones that really can't do much and are very disabled, in all the new trials, that number decreases by about half. So by treating these large core patients, we're not leaving a profoundly disabled group, as was initially might be the fear. So not only is the scanning, the technique, the triage, the getting them through the journey all improving, and the equipment certainly improving, and the medical manufacturing companies are really pushing into this area strongly. But for me, the real revelation in the last couple of years is the patient selection.
How do these techniques improve patient outcomes?
The technique of mechanical thrombectomy is performed in an acute setting. So the patient comes to a tertiary hospital, either having been to a primary hospital first or directly to the tertiary hospital. They're assessed in emergency clinically and very rapidly progress to CT scans. If patients are eligible for thrombolysis or clot-busting drugs, then they should get clot-busting drugs. And whether they're eligible or not, if they're eligible for endovascular therapy, then they move very quickly to the endovascular lab. They change patient outcomes profoundly. We have patients of all ages, pediatric to seniors, who would have otherwise been left moderately or severely disabled, who return to functional lives. We have people in their 40s who are carers for small children who return to work, who return to productive life, caring for their children, paying taxes. And that's a very different scenario to a patient that is left disabled, where their partner has to quit their job, where it disrupts the entire family, not just for today and tomorrow, but for the rest of a lifetime. So the impact of effective stroke treatment, be it with intravenous thrombolysis or mechanical thrombectomy, is really quite vast. And I think it's underappreciated how big that impact is.
How do neurologists and interventional neuroradiologists collaborate during the acute phase of stroke care?
Certainly. So this varies from hospital to hospital. I work across a couple of campuses and it is different on each campus. The most important thing is that patients get referred, so that the community is aware, so that GPs are aware, so that other specialists are aware that, if a patient has stroke-like symptoms, that they must be referred in as a matter of urgency. Once the patient is referred, we'll often get a pre-notification from an ambulance if a patient is fast positive, that they are 10 minutes away from the hospital, so we can meet them in the emergency department and fast track them. At one of my campuses, that initial assessment is done in combination with the neurointerventional team and the neurologist. Sometimes it's just the neurointerventional team, sometimes it's just the neurologist, but a member from the neurosciences will meet them, and then they're fast-tracked to imaging. The first decision that needs to be made is whether that patient requires thrombolysis, and that is a decision the neurologist will make. And obviously there's a set of criteria that go along with that. And at the same time, the next decision is whether they should be considered for mechanical thrombectomy. At that stage, the patient will be transferred to the operating theatre. Often the thrombolysis is being given at the same time on the ambulance trolley, and then the patient will receive their thrombectomy at that stage. Again, it depends a little bit on the institution. I admit my mechanical thrombectomy patients under myself, and then once they're over the first 24-hour period from that operation, then the care is transferred back to the neurology team, and then we both follow them up in outpatient clinics thereafter. The search for the cause of the stroke and to prevent further strokes is taken over by the neurology team, as well as that rehabilitation phase of the patient.
Can you tell us about the new minimally invasive approach to treating chronic subdural hematomas?
Chronic subdural hematomas, our understanding of this has changed dramatically over the last 5 years. When I was a medical student, subdural hematomas were an old atrophy brain that got jiggled around in the skull, and the bridging veins would bleed, and we developed a subdural hematoma. And that may well be the etiology for the initial subdural hematoma. What we know now is that as these become chronic or acute on chronic, that there is neovascularization of the meningeal membranes. And this leads to persistent leakage of fluid. The leakage of fluid is greater than it can be absorbed, and this leads to persistence of subdural hematomas. The traditional method of mini craniotomy or burr hole and drainage of subdural hematoma is very effective and is still very much required if there is mass effect, which is causing acute symptoms. The problem with subdural hematoma evacuation is that there's quite a high recurrence rate. And depending on which paper you read, it's between 5 and 50% reoperation rate. Now, about 20 years ago, there was a Japanese team that did a meningeal embolization, where we go up with a microcatheter into the middle meningeal artery and block that with liquid embolic or particles for resolution of persistent recurrent chronic subdural hematoma. More recently, there was a large linear case series from Korea. Now we have 3 randomized trials that show if we embolize the middle meningeal arteries in these patients, their chance of needing further drainage, surgical drainage, is reduced to single figures, about 2 or 3%. And that can either be done in conjunction with surgical evacuation if there is enough mass effect to warrant it, or as a standalone procedure to treat chronic subdural hematomas. Now, this is important not just to reduce the rate of mini craniotomies and drainage of the subdural hematomas, but it also means that our patients who often have arrhythmias, they often have AF, they are often requiring a direct oral anticoagulant, or they may have cardiac stents requiring antiplatelet therapy. It means that they can return to their antiplatelet and anticoagulation medicine more quickly as the subdural hematoma resolves more quickly. And that saves us from having further strokes down the track, such as thromboembolic strokes from undertreated atrial fibrillation.
Can you describe how the multidisciplinary approach at MQ Health benefits patients?
Look, I think I'm very privileged to work at a very academic institution such as Macquarie University. We benefit from having combined neurovascular clinics and multidisciplinary team meetings. We have a wide array of specialists with interest in subspecialty areas, such as Candice, who has a very strong interest in stroke. We have regular neuroradiology and neurovascular multidisciplinary team meetings where complex cases are discussed, and the patients get the benefit of the wisdom not just of 1 or 2 doctors, but of a whole cohort of academic doctors to try to find the safest path for them going forward.
What are the emerging trends or innovations in stroke treatment that you're most excited about? And how might these change the landscape of stroke care in the coming years?
The thing that I'd most like to see is a more effective pre-notification system for stroke. The cardiologists get to do ECGs in the back of the ambulance, and so they have the lab ready for when the patients arrive. In Australia, we don't have the volume of stroke to have labs ready every second of every day for every patient that might have a neurological symptom. So there are some companies which have some back of the ambulance brain imaging, including an Australian company. And these are in preclinical and early clinical trials. And so it may be that in the next 5 or 10 years, we may have a small esky-sized box in the back of an ambulance that will be able to give us a better idea about whether these patients need to have stroke treatment and divert the ambulance to the most appropriate centre for that and save on any delays. The delays are really, whilst we can treat patients out to 24 hours and sometimes beyond, there is a great consequence of delay. When we look at the 7 big positive stroke trials for endovascular clot retrieval, it showed that every 1 second of delay led to a 2.2 hour loss of healthy life. So a half-hour delay leads to about a 6-month loss of healthy life for every one of these patients. And so we really need to make the progress of these patients through our system as efficient as possible.
Thank you to my special guests, Neurologist Candice Delcourt and Interventional Neuroradiologist Brendan Steinfort. This podcast is made possible by Macquarie University Hospital, part of MQ Health. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thanks so much for listening.